Welcome to the video on cardiopulmonary exercise testing. We will be going through the device calibration, setting up, and performance of a cardiopulmonary exercise test. All CPET systems should be calibrated immediately before each test, including the oxygen analyzer, carbon dioxide analyzer, flow meter, cyclogometer or treadmill, and blood pressure transducer. Normally, volume calibration and verification of the calibration is done with the aid of a 3-liter calibration syringe. During volume calibration, it is a good practice to use viral filters and other hygienic precautions to prevent cross-contamination by the syringe. A range of flow rates should be performed to simulate the wide range of flow rates that occur in going from rest to heavy exercise. Modern CPET systems contain rapid gas sensors. These rapid gas sensors can measure oxygen uptake and carbon dioxide output as frequently as breath by breath. Gas calibration is an automated process. Most CPET systems show reminder messages if calibration is yet to be done. Gas analyzer calibration needs to be done immediately before every test, after the exchange of the gas cylinder, after the exchange of the gas sample tubes, and when measured results are doubtful. It is essential to make sure other spare parts, consumables, and fixations are working properly. Pressure of the calibration gas cylinder needs to be monitored. Expiry date of the calibration gas needs to be checked. Accuracy of the calibration syringe needs to be tested. Stadiometer weighing scales accuracy has to be checked. There shouldn't be leaks from CPET masks. Correct readings from saturation sensors should be available. Gas sample collection lines should be checked frequently and replaced appropriately. Minimizing the subjective estimations of the Borg scale by explaining it to the patient clearly is also very important. You can click on the New Subject tab and enter the patient identification information as well as the measured data. You will see that the essential fields needed to be filled in are in red. The test. We need to first measure the patient's height and weight. For each patient, we must start a new test and enter the patient's demographic data and the variables measured. We use a bacterial and viral filter as for any lung function machine. After entering the patient identification information and creating a new profile, we would then begin by performing a baseline spirometry to look at the patient's baseline FEV1 value. We begin by performing spirometry to obtain the maximum FEV1 and FVC value and to look at the flow volume loops to see whether the subject has a normal, obstructive or restrictive lung function pattern at rest on spirometry. The measured FEV1 is used to calculate the MVV or maximum voluntary ventilation during CPET. To begin the test, we now select the Metabolic tab and then click on the CPET Breath by Breath tab. Once you've come to this page, you can click on the Start tab and select the appropriate options for the test, type of ergometer and protocol. Enter the spirometry values obtained and select the appropriate integrated devices. We now connect the ECG leads to the ECG pads pasted in the appropriate places, which would monitor the subject's ECG rhythm and heart rate during the resting phase, test phase and recovery phase. We now connect the pulse oximeter probe, which measures the patient's oxygen saturation. Finally, the mask, which monitors the flow and measures the oxygen and carbon dioxide concentration in the breath, is fitted. It is important to select the appropriate mask and test whether there is any air leak from the mask before we commence the test. Here we can see the order that the mask needs to be fitted to the filter and the sensors. To select the appropriate mask size, we measure the distance from the bridge of the nose to the bottom of chin with the mouth closed. Then we need to fasten the mask properly with belts provided so that it is not leaking and not too tight to the patient as well. We can use a filter in between the mask and the sensor, if needed, to prevent viruses and bacteria spread into the surrounding from the patient's breath. We begin the test with the resting phase, where we ask the subject to stay at rest on the cycle ergometer for the first 3 minutes. Here we obtain all resting measurements in blood pressure, oxygen saturation, resting ECG rhythm, VO2 and VCO2 values and breathing pattern. We connect a blood pressure cuff to the patient's upper arm to record the blood pressure during exercise. Remember not to fit the blood pressure cuff to the same arm where we fit the pulse oximeter probe. At the end of the first 3 minutes, the resting phase ends and the test phase begins. We now ask the subject to start cycling and bring the speed of the cycle ergometer between 50 to 60 revolutions per minute. We ask him to maintain this speed throughout the test without slowing down. The initial 3 minutes of cycling is called the warm-up phase, which is unloaded cycling. The ECG rhythm, VO2, VCO2, oxygen saturation and various other measurements are monitored real-time during the test. The physiotherapist or doctor will be asking the subject regarding how tired he is at regular intervals using a visual analog scale. The next phase is the incremental exercise phase. It is also called the ramp phase, which lasts 8 to 12 minutes and is selected according to standard protocol. It is recommended that this phase is started without providing any cues to the patient. The patient is instructed to pedal as long as possible. Important data is gathered from the patient's expired gases. A rapid gas analyzer samples each breath. The continuous ECG, saturation, and non-invasive blood pressure monitoring is performed throughout the test. Increasing work at a predetermined ramp rate allows the patient to pedal against a continuously increasing resistance. The average CPET records a large collection of measurements. This would include the work rate, metabolic gas exchange measurements, ventilator gas exchange measurements, and cardiovascular variables. The large amount of data that is gathered is represented in a graphical form, the 9-panel or the Wassermann plots. The limit of tolerance is defined as the point at which the patient is unable to maintain the pedaling cadence despite encouragement. Monitoring continues during the recovery phase. Once the resistance is removed, the patient exercises for a further period to prevent venous pooling in the legs. Monitoring should continue until any dysrhythmia or ST changes have reverted to baseline, heart rate has fallen to within 10 beats per minute of resting values, and the blood pressure has returned to baseline. Data obtained from the CPET offers additional interpretative power over conventional exercise tolerance testing. CPET provides an objective assessment of exercise capacity, preoperative, and also helps in identification in the cause of exercise limitation. It is an important risk prediction tool and invaluable in the evaluation of the breathless patient. It is important to understand what are the normal CPET data and what a normal 9-panel Wassermann looks like. Start by interpreting common patterns of abnormality. First, you have to determine whether the test was maximal in terms of effort. The report is not auto-generated. The parameters have to be interpreted methodically to arrive at a clinical decision about cardiometabolic and respiratory disease. It is essential that regular cleaning and maintenance is carried out.